There are a number of advantages to using next-generation sequencing at diagnosis, and I think when clinicians talk about that, what they really mean are using panels of genes that can be analyzed and turned around rapidly in enough time to be able to actually influence any important diagnostic or therapeutic decisions that need to be made before the patient started on treatment. And so the advantages of using those kinds of panels are multiple. One is that they give us a real insight into the biology of the cancer. There are different types of mutations that are biologically important for different types of leukemias. They are important in predicting prognosis, so different mutations that we can detect portend a good prognosis or a bad prognosis, and that can help us then make treatment decisions down the road, whether a patient may need more intensive or less intensive therapy. And then finally, they're important now, these panels, as they're starting to be used more and more at many institutions, they're actually important for building knowledge bases and databases of clinical and genomic information that can be married together and then used for retrospective single institution studies or multi-institution studies. The pitfalls, I actually use a different word. I think I would say caveats rather than pitfalls. I don't think that there are actual drawbacks to using these kinds of genomic panels. I think that in general, the sort of advent of multiplex genomic testing has been a largely positive thing, but there are caveats. So one caveat is that there are always trade-offs between different types of sequencing. So you can do very broad sequencing where you analyze large portions of the genome, or you can do very focused sequencing where you only analyze a certain subset of genes. There are trade-offs with that in terms of time, the amount of data that you get back and that you have to wade through, and the depth that you're able to interrogate a patient's blood at. So whether you're able to detect only those mutations that are very common or mutations that are very rare in only a minority of cells. There is the need, as I mentioned before, for sort of expert annotation and analysis. So you can't just take all the data that come right off the sequencer and be able to then look at that and know what it means. You actually have to do first some bioinformatic analysis and then have somebody who actually knows what they're looking at annotate the data. And then there are certain genes, like specific genes that are important in especially acute myeloid leukemia, which is what I'm talking about, that are actually not assessed well by next generation sequencing platforms. So there still are a role for older sequencing methods in that use. And then finally, there's the fact that these point mutations are not the be-all, end-all of either prognostication or prediction in AML. There are other factors like patient factors, things like patient's age, the white blood cell count at diagnosis, large-scale chromosomal rearrangements that are as important, or in some cases even more important, than the genomics. So it doesn't tell us everything, and it's only one piece of the kind of overall puzzle.